Sup, guys? Welcome to episode 46 of the Jungle Brothers podcast. I am your host, Joe Worthington, with co-hosts Paul Fetterphilly, Tiora Ward, and
hello.
And today's guest, Anand Rajan, aka Nando.
That was a joke, everyone.
What? quick shout out to Panavore Cafe.
That one.
What's that?
That's new.
I'm coming in with the high energy,
Jesus
bro.
Christ, I've been I've only been away for 3
Yeah,
episodes.
we've stepped it up, and everyone has to talk twice as fast as usual. So you're gonna have to accelerate a little bit if you want to be on my level.
Oh, here you go.
Shout out to our people at Panavore Cafe for providing the coffee that we're not drinking today because we ran out of fucking filter papers. But check it out, we do have the coffee here. It's just filter papers, so we're going to be back on track from next week.
Great story, bro.
Paulie and I had a cool episode last week talking about injuries. I'm dealing with one myself at the moment. He dealt with one a year and a bit ago, and we went deep on just to the whole mindset and the process around that.
Can you hear me?
Yeah, we can hear you, bro.
I can't hear myself.
Can hear. We're going into a little bit of the injury piece today, but taking a slightly different angle. Nando, as we're going to refer to you as, not Anand.
Yeah, please do.
Birth name. You're an anaesthetist.
I am.
Would you please give us a little intro to yourself and tell us who you are and how you came to be here?
Came to Jungle Brothers.
Well, just came to be here on the show. What your path in life has been until this point.
I guess to make it very quick from a training point of view, I went to a number of different... I wasn't naturally a gym person. And then I went to... At some point, I did CrossFit. And they said, and I'll never forget it, you will be... we'll make you fitter and faster and stronger than you've been before. And I think that is, credit where it's due. You definitely got fitter. And I think it's interesting that those gyms came about because I was never a fan of those plasma screen TV, kind of lock you into a contract, fitness first kind of arrangements, which is why I think it was so appealing. But then, like everything, injuries and little niggles and pains start to come about. So it then led to other CrossFits and then other physios, which would say we would fix this and we'd be able to come up with a solution here, and it will be like, that's fantastic. And then when that doesn't quite measure up, then it then led to you guys. And then that's when I came in and he said, oh, look, we're going to fix this. We're going to make you fitter and faster and stronger. It was like, yeah, okay. But I think what I've found over here, it's just time. It's just spending a lot of time and having a lot of emphasis on form and doing the movement correctly and realising that it's not even a case of hard work. It's just doing work and coming consistently. And I think that has been a lot of the training journey. It's really only been this year where I think that I've started to see, I can lift this and I can move this way, and the warm-ups are a whole lot easier to do. And I think if you want to sum up my training history, that's a very, very short summary of it.
Perhaps the right work as well, right?
True.
Right?
Yeah, very true.
Not just something, but the right thing and then the right amount of it.
Yeah.
If I look at you, that you're trained from... I was thinking about this earlier. From the day that you first walked into the gym, I remember talking to you and how you came across to me as a person then compared to how you come across now on a daily basis here in the gym is like chalk and cheese, two different people. And I think that, and what I picked up a lot in that early stage was fear around training.
Yeah.
And around how your body operated.
Yeah. I think there's a lot of apprehension because it's like it came in, you got this niggling pain here that's gotten better. And at each point, like I think the first time you ever go to a gym or a process, they're like, do this and then these things will happen. You're like, yes. And then when it doesn't quite measure up the second time, you kind of go, oh, look, maybe it was just a one-off. Let's give this a good go. And then it doesn't quite measure up. So I think you carry a lot. I think that's one thing you may well realise with new members, and I'm sure you see it, that when people are coming to a new gym or come to this gym, they're carrying a lot of the baggage of the previous gyms and processes they've been through, especially if there's either an injury or something else that they're carrying with them. So yeah, 100%. I think there's a lot of apprehension in the beginning.
Tell us about you being an anaesthetist. Switch to that angle. You're a bit of a Doogie Howser. How did that come? What's the deal? I don't even understand what it is you do. I know what anaesthetic is.
It's true.
I know that it gets put in you before a surgery or whatever. But what's your day-to-day look like, and how did you end up in that profession?
Yeah, so an anaesthetist is a medical doctor, so someone who's completed med school and medical training and has then streamed after a period of being an intern and a resident into critical care, and then has then moved on to anaesthesia, which is a separate specialty and training scheme, and that's a 5-year training scheme with a series of postgraduate exams. So that's what an anaesthetist is. I moved on to it. I think you move into a lot of, when you finish medicine, the areas that you would like to go into, because I think maybe interest and exclusion. So you work out the things that you like, and then you work out the things that you don't really want to be. So I think over time I realised...
How many years do you study to get to where you are now?
So after high school, I did undergrad med. So I guess it's just...
So high school, what kind of marks do you need to get into medicine?
So when
I study involved, before you get in.
The selection process has changed now. So when I did it, it was the old school way, where you just had to work very hard at high school and then get a very high mark to get in.
A UAI or whatever it's called. Above what?
For me, it was
above 100.
It was above 100.
To get
all of us got above 100.
Minimum?
Yeah. It was high. It was just
above 95, above 97,
above 99.
Yeah. Sick.
Yeah.
That was when I was at high school. The idea of someone ever getting that was like a fantasy to us. It was just like as if anyone would fucking get that. And then here you are.
I think actually, T and I were talking about this some time ago, and I'm sure for a lot of stuff I'm going to say today, the thing about a podcast is that it's recorded for all time, and so you sit back going, oh...
Yeah, you don't want to fuck it up.
Exactly. So would I say it differently? But I guess, a lot of the reasons why I think people do quite well academically, and it tends to be, Asian Indian kids that are stereotyped in this space. But I think what is done is that a lot of it's quite gameable in its own way, insofar as you'd pick subjects that would scale quite well, and you'd pick often science-based subjects or ones where you have a strength where it will scale to a good mark. And then either with parental support, pressure, or both, you just put a lot of runtime into, and I think this is no different to a lot of gym activities. And, look, if you actually really want to look at it, everyone talks about David Goggins now. It's really like an academic David Goggins. It's like, know your territory, know how they're going to think, and it's just a case of ruthlessly learning a syllabus, working out exactly the points of that, getting every past paper you can, and just gaming it as well as you can and learning that as well as you can. So, and that has its drawbacks as well, in that you're just targeting one specific thing. But I think that is one way in which people do well academically. It's just you learn exactly what you need to learn that's going to get the best possible mark, and then you work hard at learning that thing. And then people are going to turn around going, oh, is that going to be the way you'd learn life? And it's like, oh, well, not necessarily. I'm not saying that. But when people say
it's how
that's
you become an expert at something, though.
It's what, sorry?
It's how you become an expert at something.
It's definitely how you become proficient at something. I think, especially talking to, for people in an older age group, which is probably all four of us now, it's like a lot of that is experience and time and looking at different things and working out how you learn. But at that time, if you want to do well at high school, that is one way you can do well at high school. And
so you went to high school, then you had a break. You have a break, or
no,
you went straight to uni?
Went straight to uni.
Oh, damn!
So
straight
a
back
break
into
just slows you down.
Well,
fuck. I know this because I'm still on the break.
Then how many years at uni?
I think that's one point. It really is a misnomer that if you don't go straight into something, that's a break, and a break implies that you're not using your time as effectively as possible. And looking back, it's like, I wish I'd just taken a whole lot more breaks.
Yeah, yeah,
I would have been much better for it in many ways. But I did undergrad med, which is 6 years.
6 years.
Yeah.
And you come out of 6 years and you are an anaesthetist?
You're an intern.
Okay, so then what?
So then you are an intern, which is kind of like you're a conditionally registered doctor. So I guess it's like a kind of P-plates doctor, so to speak.
Yeah.
Then you become a resident, where you are a junior doctor that hasn't picked a training scheme. So you can be a resident for as long as you wish. You can be you're a general resident for a year, And one thing in Australia, especially in our training system, is that we are very much of the belief that you should do at least 2 years where you're a general doctor. So in other parts of the world, you'd become... you'd either be a JD or a Turk. If you watch Scrubs, you either become a medical intern or a surgical intern.
Scrubs is a great show.
It was good, yeah.
So
It's
funny.
there's a lot of good calls that I don't watch medical shows in general. Like I don't watch medical shows at all. But
Except
I watch
for Doogie
Scrubs.
Howser, House,
I watch
Scrubs. What?
Did
Did you watch Doogie Howser back in the day?
A little bit. I like a few weeks ago on this podcast that you made a Punky Brewster reference. I'm like, yeah, I get that. It's like, I love being in that age vintage where I get those references now. So shout out to Punky Brewster.
But tell me, so you can fluff around at that intern stage, but if you're like, all right, I want to go to this specialized thing.
So you pick
what's the pathway? What are you looking at?
Yeah, so I mean, if you want to become a physician, you'll usually become a medical streamed resident medical officer or SRMO. If you want to do surgery, you'd be a surgical SRMO. And so if you want to do either emergency anaesthetics or intensive care, you'll become a critical care SRMO. And that's what I did in my third year out. So that is where you do terms in emergency, intensive care, anaesthetics. So you're doing those terms, but at a very junior level. And then you apply to get onto a training program, which lets you stream to become an anaesthetist. And then once you're a trainee, you become a registrar in that area. So you'll see registrars everywhere. And so after that, I became an anaesthetic registrar.
So there's more study involved in that, I'm guessing.
Yeah, at a postgraduate level.
Another couple of years?
5 years.
So it's a lot. It's like 11 years.
What's that whole journey? More than 11 years?
It's a lot of study.
What
14
age were you?
years.
14 years.
Yeah.
Motherfucker.
And the study's I'm guessing it must be quite intense because there's so many different systems you have to understand, and obviously when you're dealing with drugs,
It is.
chemicals.
So for anaesthetics, the exams are tough.
We're talking big hours with the study, like it's full time. I'm guessing
it's-
full time and then into part time.
Well, you're working full time,
Yeah.
and you need to find time to study on top of that, and go to courses and read the material and learn everything. So part of it is drawn from what you do at work, and then the anaesthetic training scheme has two parts. So part one you do early on, which is all very intense science based around physiology and pharmacology, and then the part two is just clinical anaesthesia. So you've got written exams. And then they ask you a series of Viva scenarios at the end, which is essentially just like a tough day at the office. So XYZ will have this, it comes in with this, outline your assessment, and then the scenario just gets worse and worse. And the point isn't for you to come up with the quote-unquote right decision. It's just for people to know what would you do. And we'll sort of touch on that.
Is there a right
later.
or wrong with these questions, or are they just seeing how you perform
Well,
potentially under pressure?
I think the first thing is to just make sure you do what's safe. And that's one thing. I mean, Australian trained doctors are very, very well-trained doctors. Especially, if you're going to have an operation in just a few days from now. Australia in 2019 is one of the safest times and places to have an operation. So, and Australian trained
Yeah,
doctors
that's
have a
very,
very, very high standard.
That's nice to know for you, Joe.
That is nice to know.
Yeah, 100%.
So how does the medical system get there? Because I was in London a long time ago, and I saw a surgery that was, I think it was like a not late 1800s surgery. It looked more like a butchery, like a.
Where did you
saws.
see
Oh, is it like
I was like a setup.
museum or
It
something? Oh,
was
right,
a
okay.
museum, but it was all
Fuck.
like ready to operate museum style.
Yeah.
And it was all original equipment and tools, and they'd clean. It looked amazing, but it was a fucking horrific looking scenario.
Saws
So
and
to
shit.
go from there to where we are now, it's not a very long period of time, really, when you think about it.
I think
But the amount of information that must be stored somewhere, what was the process between getting from not using any anaesthetic back then to where you are now, where you have a huge amount of selection and combinations and the rest of it, what you do as a job?
Yeah, I think it's incredible when you look at the history. So I think one of the first things is really before you had the advent of anaesthesia, you were often more likely to survive if you didn't go into hospital than if you did, because people talk about various anaesthetics that have come and gone over time, but realistically an operation before you had anaesthesia depended on the speed of the surgeon and the brute force of the surgeon. So either you had such a huge surge of adrenaline that overwhelmed your system and you died from that. In fact, there is a type of heart failure called stress cardiomyopathy that comes from adrenaline overwhelming your circulatory system, or you had insane PTSD, or you just had intractable blood loss because you moved so quickly that you didn't have time to sort of clean. I mean, it's just horrific.
What were some of the old forms of anaesthetics?
So it's funny you say that.
Like Alkas?
Yeah, I mean, alcohol, opium. I see various potions that were invented with, hemlock and various things. There's a Japanese surgeon that talks about various powders that are all mixed together, and then they're just given and kept close to the patient. They would sort of fall into some kind of stupor. And then another kind of, you put a sponge of vinegar and then it would bring it out of it. I'm mixing history now, but I think that's that kind of thing.
Bit of witch doctory kind of stuff as well, or?
Yeah, look, I mean, there's so much trial and error that went into this. And I mean, by trial and error, like you can underline error in there. And it's just a wonder that we survived as humans,
But
really.
I mean, we had to go through that, didn't we, to get to where we are?
Well, I mean,
how fortunate we are that we didn't have to go through that.
Totally. And it's the 1800s where things really changed. And in fact, I mean, as we'll go on to talk about, it's easier to just frame a lot of this around what's going to happen to you, that what's going to keep you asleep.
I'm going for a surgery on Wednesday, which is 5 days from now.
He's getting the good stuff.
I'm
You
getting
are?
the good stuff. I'm going to wake up with a Robocop knee.
Yeah, that's what I expected, isn't it? Yeah.
Stay out of trouble.
They're not going to reno everything else, are
No,
they?
they don't give me the metal face or anything like that.
Well, it's the 1800s where things changed. It was, I mean, what you're going to be kept asleep with is a derivative of ether, which was first demonstrated in the 1840s. And
What's that?
Is ether's involved in alcohol production as well?
No, it's a separate compound. So
Okay.
it's a hydrocarbon with the oxygen in between. So it's like you've got an oxygen here that's like the body that's holding two arms, which are hydrocarbons. It's a class of, it's a type of structure.
Okay.
So, I mean, how they came about is that they were coming up with all manner of things. Chemists were developing all manner of different either agents and gases, and this is around the time that people were even identifying or that a gas was a gas, that people were realizing that oxygen was a thing that was important and essential to life. And so there were two big things that really happened in the 1800s. So there were two dentists that got wind of this idea that if you gave this gas and people breathed it in, you could do dental extractions and procedures quite painlessly. And so fast forward a lot of trial and error and a lot of experimentation on yourself and unwitting people. You get to, they talk about what is the point at which modern anaesthesia really started. And the story is incredible. So, I mean, you've got two parallel kind of gases. One was nitrous and one is ether. So this dentist got wind of something called sulfuric ether. And after a series of other trials, it was October 1846. And the story is crazy that they had a man with a giant vascular tumour around the neck with various distended veins and whatnot around it. And you had a delivery system, which was a mask, and you'd drip some ether down. And I mean, I just think of if we had to do that in 2019, I would be thinking of things like airway protection, large IV access. If we cut this thing, how we would deal with blood loss. There's
Infection.
Infection.
That's a one. Oh.
I'm thinking from the anaesthetic alone, despite all of the obvious things you've talked about, like prepping, draping, aseptic technique. Anesthesia in a sitting position, so air can be sucked into a large vein, and there's various other things like that. This guy did it with no IV access and just a poor delivery ether device that just kind of dripped an anaesthetic in. And miraculously, it worked a treat. It worked incredibly well. And I mean, you can just Google the image of first demonstration of ether anaesthesia. You see a bunch of guys in suits looking at what they've just witnessed. And as the guy woke up, right towards the end, it was like we are onto something amazing.
Game changer.
Yeah, and it really was. And they proved it again and again, and then everything went from there in the ether direction, because suddenly we can do operations. We can do operations. People will keep still. But I mean, the beauty of ether as a drug is that you need very little experience, and it seems to work with whatever delivery system. I mean, there's qualifications to what I'm saying, and this is all within reason, but it's an amazing drug. And on the other hand, there was another dentist that had nitrous oxide, and that had a bit of a bumpy start because he first, after a series of demonstrations, wanted to demonstrate that it would work. Had someone who was presenting for surgery on the day who refused on the day, and so he's there with this bag of nitrous going, oh, well, does anyone else want something done? There's a guy in the audience saying, actually, I've got a tooth that needs extraction. But the point was, because of poor delivery and because of poor containment of the gas, he apparently groaned as they pulled the tooth out, even though the patient went on to say, actually, it was minimally painful.
But for the sake of demonstration.
Yeah, the guy was discredited and laughed out of it and all that kind of thing. And
Wow.
But really, one of the people that was using it was really just used as a kind of a parlor trick. So if you've heard of the Colt 6 revolver, invented by Samuel Colt, one of the big guns of the Wild West,
Yep.
he used to offer nitrous as demonstrations, just as 25-cent tricks, and then managed to amass enough money to patent his revolver. So nitrous really just helped to finance the...
What, he would offer nitrous for people to try it?
Yeah, just to sniff and just giggle a bit and then
Right, because
breathe
that's
out.
laughing gas,
Yeah,
isn't it?
and that's all it was up
Yeah,
until
right.
that point. So in the 1830s, it would be like just something you'd travel around and have a sniff of this. Whereas only over time, people like, maybe we can actually do things with this. But
Right.
finally, over time, people used nitrous. And then more importantly, nitrous is a gas that is, if you're inhaling nitrous, you're not inhaling oxygen. So it means you've got dangerously low levels of oxygen. So finally, when people realised if you deliver nitrous with oxygen itself, then you have a gas that can be used, but people will live at the end of it.
Right.
So
Imagine getting your teeth pulled out without any anaesthetic.
It's fucking sickening to think of.
yeah,
Man.
it's brutal.
I mean, imagine someone cutting you open,
yeah.
sawing your leg, like all the horrible amputations and shit that would have had to have gone down.
People genuinely got PTSD out of it.
Man, yeah,
Oh.
it's unbelievable.
So that's what I mean.
I feel like such a pussy. It's like, because you would have had to just do it, right? There's no other option.
yeah. Or you'd get very, very drunk, and chances are you'd have a big meal, and then, if any of that goes the wrong way, which is one of the cornerstones of things we worry about, then it's just bad times for everyone.
But
Get drunk, have a big meal. What do you mean?
Well, one of the things we do before having surgery is that they say don't eat after a certain time.
Fast.
Yeah, so you need to be fasted.
And that's because they don't want you to vomit.
Yeah,
have
it's a
food.
risk
Right.
of aspiration.
Yeah, right.
So you don't want any gastric contents to end up in your respiratory system.
Okay.
So that's why we have fasting times.
can you tell us a little bit about what the body does if it has to go through something like that? And you said adrenaline is what it'll deliver. Is that how does it work if someone has a finger cut off and they're isolated, and how do they deal with that sort of pain?
How they deal with pain in general?
Yeah, how would they
Let's
deal
say
with
like
that pain
like
if
the
I
rock
cut
the
myself?
rock climber had to cut his arm off.
Yeah.
Something like that. Like what
Mid fucking
how's
rock
the
climb.
body helping him deal with that pain in that survival story?
Well, I mean, pain is the sort of the long sort of held definition, which we have of pain now, is an unpleasant sensory or emotional experience characterized by actual or potential tissue damage or described in terms of such damage. So what they talk about is, and that
you
just
have to
covers
write that
everything.
in an exam
I had to
once?
learn it over and over and
Tattooed
over
on
and
the
over
back of
again.
his hand.
You believe me, every anaesthetist who's out, every trainee who's passed the primary will know that definition off by heart.
Right
it's, just
on.
it's one of these things where it's a bit kitschy and cliche, but everyone has to learn that.
It covers every little avenue.
It
Because
does.
obviously
Perfect.
you can still feel pain without... I mean, people experience pain without a cut or without any sign of pain, and that would be something psychological.
Well, there's actually a few things. So now that I have this, it's like what they call is a multi-order neuron pathway.
Stay close.
So, you with my back? Yeah, I can hear me now. So just say you cut your finger. This is my sort of bad picture
He's
of a
drawing
finger.
a finger.
So what it is,
It's the middle one.
and I'm drawing this here, but you don't need to see it by any means. You have one signal from your periphery to your spinal cord,
The arrow.
and then from your spinal cord up to your brain. And then there's various influences that it'll synapse around parts of the brain, but also your emotional center. And then there's levels of descending inhibition as well. And I think that's what you're referring to, the people who don't feel pain because of various other influences or an intense amount of pain. It means that there are ways in which you can either reduce the amount of pain or modulate it. And there's a term called the gate control theory of pain, which talks about that. But essentially, to put it down,
that's something you can train.
Short answer is yes, but I can't really comment beyond that. What I can tell you is a whole lot about which point at which you give the drugs that work, and then there is an emotional component to pain, and that can certainly be modulated. So people who feel a lot of pain because they anticipate they're going to feel pain are definitely going to feel like they subjectively hurt more, which is why that definition is sensory or by or described in terms of such damage, because you don't necessarily have to have the damage there after a while to say that it hurts.
Yeah. So there's a big perception thing going on there.
Yeah, totally.
There's that famous story of a builder who shot a nail through his foot into a piece of timber he was working on, through his boot, screaming, fucking just put a nail through his whole foot. They had to cut the board off. They took him to hospital. They had to delicately remove his shoe. And he's screaming the whole time, and then they remove his shoe and they realise the nail's gone between two toes.
Yeah.
And he was in serious pain until that moment.
Yeah.
I can't remember where I heard that, but that's a great story.
You never went back to the work site again.
Yeah.
Well, I mean,
got slabbed.
They also hear of people who have got phantom limb pain, who even with an amputation, who then sit into a double-sided mirror so that as soon as they can see what was their limb, with their good limb being mirrored across, and then the pain leaves. So
they start stretching it and stuff, don't they? They can open it up.
There's always stories like that. But to come to a more acute thing, like one thing we can concretely talk about, which is what's going to happen to your knee, there's going to be essentially a peripheral sensitization. So, when somebody drives an actual scalpel into your knee or someone cuts your hand, there is a signal from the periphery to your spine. And there is a period of what they call peripheral sensitization. So it means that you've got fast and slow pain fibers that will transmit pain to your spinal cord. So you get that initial sharp pain, and then you get that throbbing pain that follows. And that just depends on whether the nerve signal that is sending it is insulated or not. But what it means is there is an amplification process that'll happen at the periphery. And so to explain it first, and then we can explain how the painkillers all work. So there'll be an amplification from the periphery to the spine. Within the spinal cord, broadly speaking, there are pain-specific receptors, and then there are ones called wide dynamic range, which will just transmit depending on whatever stimulus is there. And so if the stimulus is unchecked over time, there are various receptors that are plugged, and if you fire enough signals, eventually they will unplug and then transmit more fibers, and that's called central sensitization. That will take a period of time and stimulation. And then there are ascending pathways that will transmit pain, and then there are descending pathways that will reduce or modulate pain. So, yeah.
So what you're saying, to kind of get an overview of that whole thing, is that that's all related to feeling pain at one specific site, but it's all these different potential pathways that the pain signal can take?
Yeah.
Is that what you're saying?
Well, yeah, and it also is how we'd address pain. So how we would tackle your pain at the end of it is there's this concept of what they call multimodal analgesia. So you have a combination. So we talk about something called the WHO pain ladder, where you have simple analgesics, so paracetamol, and then that broad class of what they call non-steroidal anti-inflammatory drugs, which is your Nurofen, Voltaren, Naprogesic.
You said the signal. So I just want to go back a couple.
Sure.
You slice yourself, cut yourself. As an example, I cut myself. Body sends a signal to the brain.
Yep.
Brain
eventually, yes.
Yeah.
Yep.
So you ascending signal, then you got descending signal. So that signal gets sent back. What's that doing? What is it going to release? Some kind of something into the blood? Like, why is there a signal going back?
As in, why is there a signal that will decrease the pain? Well, they talk about in terms of control systems, there are positive feedback loops and negative feedback loops. So
when it goes back, is it telling the nerves that are sending the signal to the brain to chill out? Like, what I don't understand.
So the descending signals, there are descending signals that will which will tell you to chill out if they're activated, and then there will be continuing ascending pathways that will say keep it going. So the descending ones will modulate in some way.
There's a lot that could go potentially wrong there, yeah? Like your ability to interpret pain from a certain like injury could be heightened, or it could be quite dull, depending on the individual.
Well, it also depends on the site of pain. I mean, rather than look at it as right or wrong, it's just going to be where the site is and where it's going to ascend to.
Can you give us an example?
Well, I mean, if you're having appendicitis, that was one thing. It's like I realise I've been on the other side of this, so as a consumer of the product.
Extreme pain?
Yeah, it's very unpleasant. So if you've got pain from an organ, then it won't be as well defined. And so what you classically have in appendicitis is where you have generalised abdominal pain, and then as the inflammation progresses, it will classically shift to the right lower abdomen. So that is an example of where there is a specific site affected, but because you don't have the nerve signals as well concentrated, you'll get dull or diffuse pain. So you'll get what they call non-specific pain, which will eventually localise. So that would be an example.
So does the body have more nerve systems to deal with pain, to receive pain and stuff on the peripherals than it does say on the inside?
It means that there are more receptors. There are specific receptors on the skin, right throughout the body. So there are going to be what they call mechanoreceptors and then nociceptors, so pain-specific receptors, and these are widespread throughout the body.
And you got your visual feedback as well, which I guess is a big one, like watching a bolt go through your foot and then interpreting that as something that's very painful, whereas something inside you can't actually see it.
Yeah.
You can't see the cut or the damage, so it's harder to isolate it.
And if
like say that thing where I mean, obviously there's stress hormones, but like someone's in a fight or something like that and they get injured or cut and they don't know about it, and then they see it at the end of the thing and it's like, oh shit, like my eyes, my forehead's got a massive gash on it.
Yeah.
And obviously all of my toes broken. I mean, you see it all the time in UFC,
Yeah.
And I guess that a lot of it's masked by adrenaline and whatnot, but it's also that, oh, I'm actually injured now. Oh, I can feel it starting to hurt.
Well, increasing availability of noradrenaline can actually reduce your pain. Or that's one of the things that can modulate pain. And in fact, there are drugs that will increase the availability of noradrenaline that are used in reducing pain. And in fact, actually, for your kind of surgery, I'd probably be inclined to give it, but we can come to that.
Would that be something that the descending signals from the brain would be triggering?
Yes. Or yes, it would be.
Right.
But the other point you had brought up of visually seeing things, that as the pathways ascend to the brain from the spinal cord, it'll also go through the emotional centre as well. And so that would activate the emotional component or through the limbic system. So that's why that visual idea of seeing things would, as you'd say, heighten the perception of pain.
Yeah, right.
Very.
Like it's so multifaceted, isn't it?
It's huge.
Yeah.
It really is. I mean, not all of it is going to be useful for us, but that's evolution. We are just adapting as best as we can.
Yeah.
And I mean, I guess remember a lot of this was fundamentally designed to protect, just so that you don't have an injury and then go at strength and movement as hard as you can. But whether that ends up helping you is another story altogether.
Yep.
There's a lot of so going back to the whole trial and error thing. How long does it take for one of these drugs to actually be available to general population? Because I'm guessing that like nowadays in today's world you can't just go out and test on humans like you could in the 1900s and people are putting their hands up, or is that the process? Do you get a bunch of
If you do it properly, then the answer is many years.
Right.
Yeah.
But if you do it on the sly,
or if you go
dark web, I need some volunteers.
I'm actually thinking more like
We'll
a health
pay with
food shop,
Bitcoin.
but then like it's one of these things where people go, oh, look, I think this I've got a tree at home, and if I rub it here, then my arthritis gets better. I mean, there's nothing tested about that, but there's nothing to stop me selling it from people who strongly believe it would work. But to go back on track and actually answer your question, the answer is many years. So, I mean, if you and I here developed, some sort of, I don't know, food that could make my headaches go away, we go like, how are we going to make money off this? The answer is that you would have to firstly isolate exactly which part of that food was doing the job, and then it would be through a process of isolating and synthesizing that. I mean, to answer the question really broadly, it would be work out all of the therapeutic and side effects, and then go through a series of stages of testing it with healthy volunteers, testing it in a small select group of the intended population, then do further trials involving the general population, and then mass production from there. And I mean, by the time you do all of that, years have passed.
And then you'd have the data that you need for a long-term effect of whatever it is that you're
Or you
supplying,
could skip all that and hire a marketing team or get a celebrity to start using it.
Well, these guys have marketing teams as well, and quite possibly celebrities as well. But if you want it to be subsidised by the government to actually help people, then you need to go through
On that
an
level.
actual process.
Sure.
I saw a thing actually just on that, an email someone forwarded me that they got from a supplement company they buy off, but that it was a campaign from the supplement company in conjunction with other supplement companies saying that the Australian government wants to, they want to move sports supplements, nutrition supplements, from a food category to a therapeutic use, more like a health category,
Right.
which means that they'll undergo much more stricter standards and testing, and the regulations will be tightened up. And it was an appeal to stop this. So it was sign our petition because you're going to see heaps of supplements go off the shelves, and I thought, fuck, it's probably an awesome thing.
Well, doesn't that just say something?
It's probably great. Yeah.
Totally.
That's awesome. So
I should buy as much as I can now while it's still on the market.
of all the stuff that doesn't work. Or I can wait till they come into action and just buy what works. There'll be just one whole shelf of whey protein and then another shelf of creatine, and
That's
will
it.
be
Yeah, no test.
There's nothing else.
Yeah.
Every ASN shop in Australia.
Downsize.
Then you'd have fortified whey protein, unfortified,
A bit of fish oil
paleo whey. Oh, who knows?
and lots of steroids.
So what's going to happen? So next week I go in and I'm in hospital for a day and I have an ACL repair.
Yes.
Which is a ligament in my knee, and then they're going to repair the old one that's what's left of it, and then they're going to do an ACL reconstruction. So they're going to take 2 tendons off my hamstring.
Yep.
And they're going to double them over to make 4 strands. They're going to turn that into a new ACL, and they're going to screw through the bone, the thigh bone and the shin bone, and they're going to attach it. And then they're also going to stitch the meniscus down because the meniscus is a bit lifted from the bone.
Yep.
And then I'm good to go. What's gonna happen? So I'm going to go in at the beginning of this process, put the gown on, and then what?
Yeah. So, you'll go into, after you get your checks and your obs and everything like that done, you'll go to the anaesthetic bay. And unless they've made contact beforehand, so the anaesthetist is involved right through what they call the perioperative period. So from before you go into hospital right through to discharge, it's, I guess the old sort of stereotype is that someone you just meet there and then you never see them again. But the involvement is really right throughout the process. And it's easier for you, who is a fit, healthy, young human, but...
Ish.
You called me old before.
Young-ish.
I said we were in the same age vintage, didn't I? Or something like that. I'd have to listen back into it.
Read between the lines, Nando.
Oh, Punky Brewster for the win. That's all I keep coming
True.
back
It was
to.
me that referenced it.
But to just, so at that point you'll meet the anaesthetist, most likely, unless they make contact with you beforehand. So if you're quite unwell, chances are you'd either go, if you're, say, in the public system, you go through a clinic beforehand and be worked up, and there would be planning needed. In this case, they'll have a pretty good idea of what they're going to do. But after they assess you, they will go through all of your history. They'll do an airway assessment, so they actually have a look, try and look at how hard it would be to actually intubate you if they had to, and they would do that for any patient
Like get tubes up through my nose and
so
down my throat?
If you sit up straight right now, just open your mouth wide as you can, put your tongue out as far as you can go, put your chin down a bit. Yeah, you'll be fine. Bend your neck back. Yeah, as far as
Roll your eyes back.
No, you'll be fine. You'll be fine.
Laybacks. Get that bottle of whiskey on the shelf. Yeah, okay.
I never thought about it that way. But maybe I will now.
I bet you do that with all the girls.
So
Because it's true.
you'll get some IV access. They'll put a cannula in. And then when people talk about getting a pre-med, what you usually get is midazolam. So that's the little
like
brother
that
of
one.
Valium. Most people have heard of Valium. You go like, oh, it just relaxes you. But it's a class of drugs called what they call the benzodiazepines. And they are a class of drug that essentially have 5 functions. So sedation, anxiolysis, they will produce skeletal muscle relaxation in high doses, and depending on the drug you use, they're an anticonvulsant, so you can use it to terminate seizures. That's not why we're using it today. But one of the most useful things about it is antegrade amnesia. So you may not remember a great deal after you get it, but I think most people don't really want to. And what it does is that you have signals that are excitatory and you've got signals that are inhibitory. And it makes the inhibitory receptors and signals work more efficiently. And that's how you tend to just relax. So when people are like, oh yeah, I got this stuff and then I just remember waking up, that will be one of the parts to play in it. So you'll get a pre-med, you'll go on into the theatre, then there'll be a period of pre-oxygenation while they put all the monitors on. They'll usually give...
And I'm kind of with it at that stage, but not really with it.
Yeah, essentially, yeah.
Yeah.
They'll probably give you some sort of painkiller. The most likely one is called fentanyl. So you can give any kind of...
Fentanyl, that's the one that's taken over the illegal drug market in the USA right now.
Yeah, I believe it's always changing,
Been
isn't
watching documentaries, yep.
it? Yeah, it's this year's season. But the drug's been around for a very, very long time. And what that will do is help to obtund your laryngeal reflexes when they put in an airway that'll help you ventilate while you're asleep. So... what it is that people go, oh, I just get given something and then that's it. You get an induction agent when you go to sleep, so you need something that's going to actually anaesthetize you. And the reason is we come back to ether. There are stages of anaesthesia described with ether. So the first is that you will become drowsy. And then the second, which is the most dangerous stage, is essentially where your brain disconnects from the muscles. So you still have your reflexes intact. So you can become hyper-combative and hyper-reflexic. But remember, there's also your vocal cords that respond to one thing when they're stimulated, which is to shut. So that is the most dangerous stage where people can get combative, but you may not be able to oxygenate them in any meaningful way. So you want to ideally get them through that stage as quickly as you can to the third stage, which is anaesthetized. If you keep giving more and more without monitoring, which is what you did with ether in the old days, you'd reach stage 4, which is cardiorespiratory depression, and then finally death. And
Because your heart stops beating.
you just keep giving more and more ether. So that was described with ether, and mercifully now we have a whole stack of monitors that will alarm and prevent that from happening, and staff who are trained in doing it. So that's the reason why you'll get an induction agent, which for the most part is most likely going to be an IV agent, which is almost definitely going to be propofol. And that's a drug which, people talk... It reached fame because that's the stuff that Michael Jackson got given to sleep. And that's kind of people go, oh, is it the Michael Jackson drug? And it's like, well, firstly,
Yes.
Michael Jackson had a lot of drugs, but that is one of them. But let's make no mistake, it's an IV general anaesthetic agent.
Yeah.
And it will induce unconsciousness.
So by the time I'm getting that, the other stuff that I've had has kind of already knocked me out?
It'll
what
have
I'm
kicked in
picking up?
and it'll synergize. So every drug will synergize with the other one. You could give a large amount of propofol on its own, but that's usually not what is done. There's variances right throughout what you can give, but most likely you'll get pre-med, you'll get some painkiller, and then you get some propofol that sends you off to sleep in a dose appropriate for you. Before you go to sleep, though, you'll receive, they go, they put the mask on. That's just oxygen. So your lungs are the largest store of oxygen in the body, and you are consuming oxygen at, for a 70-kilo adult, roughly 250 mils a minute, and you've got a store of roughly 250 mils of oxygen. That's why people talk about if you suddenly collapse, that golden minute. start doing things. If you pre-oxygenate and fill your lungs up completely with oxygen, you can extend that time of oxygen storage to many minutes. And that was from the days where you couldn't necessarily intubate someone or you couldn't actually get the airway in. You had enough store for the drugs to wear off and to try and wake up the patient. But, just about everyone receives oxygen for a period of time before they give an anaesthetic drug. Because even though we did that assessment there and had a look in your airway and go, it'd be pretty easy to ventilate you and to be able to establish some sort of tube if we had
Might
to.
not happen.
Yeah, there are always going to be cases where it's going to be difficult for that to happen. And then I suppose later on we can talk about just crisis management and drills that we all learn, which is, the cornerstone of a lot of what we do.
So Joe's getting a needle in his arm.
Yep, he'll get a cannula. So the needle just inserts a
Yep.
small straw,
Yes.
and the straw is just a conduit for giving whatever medications.
So when I had my ankle
That's right.
surgery,
Yep.
They gave me nerve blockers.
I'll come to that as well.
Which was a little
I want the
different.
fucking nerve blockers.
Which was, I think it went in through my hamstring.
You'll get a nerve block, yes.
So I think I had something to chill me out first. It might have been a gas or something, but I was pretty much awake when they were giving me the nerve blocker.
Yep.
How is that very different to what? Is that
Yeah,
completely
so-
different to what Joe's getting?
No, I think
And why would they have chosen the nerve blocker? Was that specific to the part that they're working on, or?
yes. So it would be, especially for orthopedic surgery, I would offer a nerve block to Joey.
Because you don't want me to become combative?
No, we have plenty of drugs that can deal with that. No, it's going to be not only excellent pain relief, and I think there's no better pain relief than a really effective nerve block. And to look into that, they go, what is a local anaesthetic? And it's any drug that will just prevent transmission of a nerve signal. So if it's a beautiful thing, really, that if you
Can you buy it over the counter? Because
No.
sometimes people get on my nerves and
Oh.
I like to be able to
It says, no, don't do that.
you can't, and even if
Smiling, everyone.
even if you
Got a
did,
big
you'd have to
grin
know where to inject it as well.
Imagine if T couldn't feel like pain for a day, you just go to town on him. Baseball bat, ground and pound.
I'll tell you what, you leave in the hands of two athletes who know how to fight, and
That'd be awesome.
I wish it
wears
worked
off.
that way.
Yeah, it does.
These are, when you know it's a good drug, you know they'll guard it like hawks. No, a local anaesthetic would not only be effective pain relief for this procedure, but it would also it would spare the amount of anaesthetic and other painkillers you'd need to give. So instead of having to belt you with a whole lot of other opiate drugs, it means that if you can find exactly the right spot to target a local anaesthetic and prevent the signal
Break
from
the
being...
line.
Yeah. And it means that you don't really need painkillers for a signal that's not even being transmitted.
Do you need to? Do you need to insert a needle into a nerve, or
No.
do you just insert it into an area?
That's a really good question. The answer is no, you don't insert it into the nerve. Because you get nerve damage
'Cause
if
that'd
you
fucking
inject
hurt.
it. Yeah, it will be extremely painful and it will be detrimental to the nerve. So no, it's not injected directly into the nerve. You'll get nerve damage by putting it into the nerve. And to that end,
You put it where?
so I would put it in proximity to where the nerve would run.
Into muscle tissue?
Yeah.
Lymph.
So you would put it into the connective tissue around where the nerve would... it would depend on which nerve you're
Yeah.
targeting.
Yeah.
And where the site of the nerve block would be. So say for shoulder surgery, we would... let me take a back step and say that where you would insert anything in the first place with a needle it used to be a case of you'd find landmark techniques. So with our knowledge of anatomy, we would know, right up the top here, they call it Navy with Y front. So you know that you go nerve, artery, vein as you run from lateral to medial. That means if we feel the pulse of the artery, then we know that lateral to it, the nerve is going to be there. So you'd find, an inch out, you could put a needle there and inject some local anaesthetic, and that would probably numb things. And even as we're just looking at you as I'm talking about that, that's a pretty crude way of doing things. They can either find a nerve stimulator, which is a small electrical pulse, where you would, as you direct your needle to the site there, it would deliver an electrical signal which would make sure that you're close to the nerve, but not, as you had described it, injecting into the nerve.
Right.
And so that was there at the beginning of my training, but now pretty much how we would do any nerve block of this type would be under ultrasound. So I would put an ultrasound probe there. I would find where the nerve would run or the site where it would run, and then I could use it so that I could exactly see where my needle is going. And that's a great, it really is an amazing thing that when you find the area that you're trying to target, the amount of drug and concentration of drug is very limited. But by getting it in the right spot, that's going to give you hours and hours of pain relief.
Mine took a long time to wear off.
Yeah.
Completely.
And that'll be not only the...
You said days, right?
I think it was like a day and a half until I thought it had worn off.
Yeah.
But then I truly knew when it wore off, when the excruciating aching and pain came in.
Yeah.
And that was some day and a half later.
Yeah, and that's something we now have available to us. So for knee surgery, I would offer that. I mean, it'll all depend on whatever your anaesthetist is going to do on the day.
Well, can you have a chat to this guy?
I'm sure he would know. I'm sure.
For the record, I did request Nando if he could be my anaesthetist. If I want that guy to stick me.
Hang on.
Be that dude.
Is your sister an anaesthetist as well?
She is.
Okay.
But it doesn't work like that. You get who you get. They're paired up with the surgeon.
The link to the
Nando
surgeon.
tells me.
You'll no doubt have someone who is very well versed at this, who will do an excellent job, no doubt.
Do you guys talk shop a lot?
Fucking bad.
Yeah. Yeah, we do. Especially when there's...
Pretty rare.
when there's a...
shit job.
I mean, it's not like the core of what we talk about, but we... when there's some difficult case and I want a second opinion, it's nice to know there's someone who and vice versa. It's like, how would I tackle this? Because, I mean, when you go, you can either have very well people for quite elaborate surgery or very unwell people having a very simple procedure, or the surgery itself is going to be quite involved in different ways. And it's all going to be an interplay of exactly how you do that. So it'd be, you're monitoring access, airway, drugs, equipment, what I would use in this case. So for you who's fit and healthy is having extremity surgery, it's not going to be as complicated as if it was, the usual things like brain surgery or long duration gut surgery or things like that.
What determines when you would choose to go with a local as opposed to a general anaesthetic? Local being just the site, you're still kind of conscious.
Yeah.
You just can't feel the thing, and then general being you're knocked out.
It would be, there'd be a number of factors, but it would be patient, surgeon, anaesthetic. So if it's going to be extremity surgery that's not expected to be of long duration, that's going to be well covered by local anaesthetic, then you could definitely do that either under local or with a bit of sedation. So sedation, by definition, is any state that they say quote unquote moderates or soothes, and there are a number of different agents you can use in order to achieve sedation. So quite often, if we have simple plastics cases where a lesion needs to be cut out or something like that, or ingrown toenail repairs, we will quite often just give a dose of some sedation so that they either don't remember it, or what they do remember it is quite pleasant. A whole lot of local anaesthetic is injected in the area to block it, and then they sort of come to, and then they generally just either have a snooze or something like that. But you've got to have a patient that's willing to do that, a surgeon that's willing to do that, and then the type of surgery that is appropriate for it.
Right.
So where that exists, that's fine. I mean, like for your case, we haven't even talked about neuraxial or regional anaesthesia, which is things like epidurals, spinals, etc. But I mean, that would in theory be an option for something like this, but I don't expect that would happen in your case. So you could have that and then you could be awake, but I don't think that is what will happen to you next week.
Yeah, okay.
So, Anand, you obviously you're a firm believer of evidence-based science and evidence-based data. Now, there's a lot of information out there on the internet and movements around medicine and health. There's topics you could talk about for hours. I've got a bunch of questions, but I'm going to ask them almost like a game. So,
Like a rapid fire.
Yeah. You guys can join in too if you want.
This is cool.
So we got we got like pseudoscience, evidence-based science. We could call it like fact or fiction. That could be the answer. So all I'm going to do is throw out like a sentence.
Okay.
And you can answer only with fact or fiction.
That's what we say. We say fact. We say fiction.
Fact or fiction. Yeah.
Okay.
I
love
can't. I will do this with a lot of qualifiers, but I will
Now
try.
remember, this is personal opinion, so it's not necessarily...
That's when it gets really dangerous.
Yeah. So let's start with...
I'm very gullible.
Here we go. Robot surgeons.
As in,
Do they exist?
What
or-
about them?
Well, yeah. Oh, is it a fact or is it a fiction or is it a potential fact? Or
well,
is
it's
it
fact. We have robotic surgery.
fact?
We
Oh,
actually have
everyone's fact.
Yeah, fact.
we have robotic
Fact,
surgery
yeah.
now. We're only going to have more of it. It's a fact.
Okay, well, here's the next one. Essential oils and their health benefits, such as increased focus and potential cures of melanomas.
Fact.
Fiction.
Limited or fiction?
No, it's fact or fiction.
I can't say that.
Recorded.
Direct relation between vegetarians and repetitive strain injuries.
Well, in that I have
Fact or
vegetarians that
fiction?
cause me repetitive strain injury. I don't even know where to start.
Fact or fiction?
Well, I can't say that's fact. So it's fiction.
Fiction.
Yeah,
Come on, Anand.
I don't know what that means. So,
He's saying
Vaccines
he
can
says-
cause autism.
yeah, it's fiction.
Fiction.
Yeah, it's actually in its own way, it's quite a sad story.
Aging is a disease and not a... aging is a treatable disease and not an inevitable act of nature.
I just heard that one.
Aging is indeed an inevitable act of nature. It's fact.
I would say to
Well,
Ellen,
wait.
it doesn't matter what happens, you look great.
Yeah, go on.
It's just the
Yeah.
perspective.
Aging is a treatable disease and not an inevitable act of nature.
Well, I mean, there's so many assumptions you got to believe. One is that aging is a disease. I wouldn't necessarily say
David
that.
Sinclair, well, his whole book, his new book, is all about how he believes it is a treatable disease and it should be classified as such.
Oh, the 140-year thing. Is that
Yeah.
the
So
lifespan?
it's interesting. I'm still not sold, but I'm like, I'll listen to what you got
You
to
still
say.
died 140 years though.
Hey?
So you-
Well, that's
so you're
right.
aging.
You're still aging.
You're forever
It's just-
aging.
yeah, you're just changing
So
the...
I'm aging now.
Geez, the T800 had a lifespan of 120 years. So you're saying you can outlive a Terminator?
T800?
Yeah, wasn't it? It's Arnold Schwarzenegger's.
Oh, was that his model?
Yeah, he's a
Yeah,
T800.
okay, and then T1000 was Terminator 2.
That was Terminator 2.
Yeah, okay.
Isn't that 120 year? Oh, that's the lifespan of the CPU, wasn't it? The T800.
Something like that.
Yeah.
Geeks.
5G radiation
100%.
and its effects on small cells in the body.
Go again.
5G radiation and its effects on small cells in the body. Detrimental effects.
I haven't read the studies.
Yeah.
Fact or fiction?
That I'm with Joey's answer. I've heard none of the evidence to make a comment.
Throw it out there.
Give us
Patients
one
waking
more.
up in the middle of an operation and not being able to move or talk, but can experience all the pain.
I've heard about this. This is a
Yeah.
thing?
Yeah, it is a thing. Like, I can't say that is fiction. Like, that is a fact. But, will that happen here in Australia in 2019? Extremely unlikely.
Fluoride is a neurotoxin.
I don't think so, but I don't know enough.
Fluoride
about
in the
it.
water.
Yeah.
It's a big topic.
Yeah, you're
In
right.
Byron
actually.
Bay.
Big
Well-
topic.
Well, what I do know is, the Byron Bay Council voted to remove,
Remove it.
Did they?
fluoride in the water, which is now that area now has the highest rate of dental caries in the country. At least that's
Actually, really?
yeah.
When did they remove it?
I think this is not a new thing.
Holy shit.
I hope what I've just said is wrong, and I hope that it is back. And but that is what I have heard. But then
Yeah,
I've
they
also
don't have fluoride in the water anymore.
but then I've also heard that third hand and from the internet. So that could just be nonsense, and I really hope it is.
Meditation leads to volume changes to key areas of the brain.
I don't know what volume changes are.
Well, you get smart, or you get smarter in certain areas. Like you have physical change to your brain.
Yes.
You'd say fact?
Yeah, fact.
I don't know
Physical
enough about
changes to the brain based on meditation? Sure.
it. I don't know enough about it.
Do you believe it? Would your instinct say, "Oh, that sounds about right"? I guess is what.
I think this
Because we
is.
can't say fact or fiction because we don't know. But it's like, does
It's
that
a-
sound
it's just
likely?
opinion.
I
Opinion.
think this is exactly the problem we have now, where people go, "Oh,
Yeah.
look, that sounds about right, so that must be true." It's like where people don't go directly to the source. And I think if there's one thing which I can make as a global statement is that when you receive that thing on Facebook saying the study has shown blah blah blah, what I would encourage people to do is rather than share the link, is to go to the study, read it yourself, and then make your conclusion. Because what you're getting from the article going, study showed this, is a third-hand interpretation of a particular finding. Because just say our study shows that, I don't know, if I eat Cocoa Pops, I can lift 20% better. And I go to the study and I realise, they tested 10 people and it was funded by Kellogg's. Then it's like, well, that's a much better conclusion.
How does a normal person find that study? Because often newspapers, they write
PubMed
with studies.
PubMed, Google Scholar, that would be good places to start.
But here's the thing:
are they all available to the public?
So Google Scholar and PubMed are freely available online right now.
Google Scholar.
I probably wouldn't be able to decipher. If I read a study on, fucking latest ketogenic trial, whatever, I'm probably not going to understand what I'm reading, right? In truth. So
have you read one? Have you tried to read one? You might be able to.
I have tried reading some. I've tended to just read the conclusion because I'm like, all right, this seems like a summary.
That's okay,
right?
But you can also read. You can also read. They'll talk about the test group, the control group, and stuff, and that's a lot of the part of you trying to figure out whether you believe it or not.
And there's always a conclusion.
It's true.
You can just go straight to the conclusion.
And
that's exactly
Google
what I just
Scholar.
said, bro.
Yeah, that'd be reasonable places to start.
Because I remember going to uni a long time ago, and we had access to a database.
Yeah.
And the database had all the papers, but you couldn't get to that database of papers without being as part of the uni and a student and having the login.
Yeah.
So that was many years ago, and I'm not aware that you can just go and, if I wanted to find something out about a topic that I heard on Facebook, can I just hit Google and do that?
Yeah, of course you can. Okay. And bear in mind when you go,
I don't do that.
I don't have, when you say I don't know how to appraise a study. Remember, there's scores of pages on the internet showing you how to critically appraise a subject. There are plenty of tutorials, video and online and similar, talking about basic ways of understanding statistics. These are freely available, and they're all available just with a Google search. It's just actually going through it.
It's putting the time into it.
Yeah, and then when you look at it, then, if when they go, there's a study showing 15 people have done this. There's more than 15 people that come to Monday afternoon strength and movement. There's 20 plus people who go to Fight Factory. And what you're really doing with any study is just looking is that what is this artificial finding generalizable to my practice and to the population? And yeah, PubMed and Google Scholar are just two things I've just pulled out of the air. But you look at, you're right, there are databases available to people signed up to universities and similar, but you don't necessarily need that for answering simple questions. But the other thing is, bear in mind, is when you get this, thing that you get sent, this clickbait on the internet, is go to the source first. Have a read of that. And
do you think that in the age we're in with social media and people getting curated news delivered to them and all those things, that and the spread of information just being that much more rapid, do you think that there's more of a need now than there was, more than ever, for people to know how to sift between what's maybe not what's true and what's false, but what's just blatant bullshit and what's, of a high quality?
We've got an interesting time now where you don't have any lack of information. And what you've got to look at is, where is the information coming from? Whether that information itself is something newly generated by that person or just, clicked on from somewhere else. And the other thing is when people are treating opinion as being a valid way of changing their practice. So I think the issue now is validity of information rather than availability of it. I'm talking to people, as I keep coming back to our age vintage, only because you've got people who knew a time before there was the internet where you'd either just have to go to a textbook or that library encyclopedia. We just don't have to do that anymore.
Yeah.
But what we need to do is that what we had then was much fewer sources of information, but had to pass some kind of process in order to be published. And at the moment I say that, I know there's going to be people listening there going, yeah, but that would have been, that could have also not been true. It's like
government conspiracies.
100%, yeah, that's right.
But the chances are it was much more credible than a lot of what's out there now.
So I should defend that what we actually have now is a great thing. We have greater access to information than we've had done. But what we need to do is to constantly vet that in our mind to make sure that what we're passing on isn't spreading further misinformation. Or The other thing is that when I go, oh look, all I have available in this in this area or topic is expert opinion, is to go, well, I mean, there's nothing wrong with that, but you need to be aware that that is all that is there, and therefore this conclusion may change over time. So you remember this is the other thing where people get pride. It's like, oh, you said this, 5 years ago. It's like, yeah, that was me then. And I'm sure,
evolved.
and I'm sure when I look back on this podcast, people said, "Oh, you said that there," or "That fact you said wasn't quite right." It's like, sure, this is what I said at this point in time in November 2019, and now that I listen to that, I go, "Oh, you know what? I think differently about this." Or, "Oh, yeah, you said that about that, that pathway, and that's actually not correct." You're like, "Oh, yeah, fair enough." Rather than, that's now concretely set in stone, and therefore you shouldn't progress to this thing you really want to do.
Yes.
I think that's the other thing, is to have a lot more compassion for what is being said at that point in time, because now you've got information being bombarded at you. We need time to digest it and time to look at it properly.
I wanted to ask you, just back on the drug thing.
Yeah.
We're going to wrap up in a couple of minutes.
Yeah, sure.
I wanted to know, because I think this is very relevant for listeners.
Yeah.
And it's something that I heard from Rhonda Patrick, who is often on Joe Rogan's podcast.
Okay.
She's she's a biologist or something. She knows
she's
some
smart.
She knows some stuff. And she said she's really smart. And she said that she would categorize anyone that uses any kind of medication, like a painkiller or over the counter things that we take, pretty much for granted here, right, in this time. But anyone that's using them at least once a month, she would consider to have a dependency on. So she said, like, women who are taking Nurofen for a couple of days a month because of period pain, I would consider that they have a level of addiction or dependency to that drug. And I was like, oh shit, wow, that's really something, because a lot of these things. I got a mate who used to like drinking a lot, and he'd just wake up and pop 2 Nurofen in the morning before he'd get out of bed, and that was his thing. But he never would have looked at himself as, someone that has a dependency on the drug or is perhaps abusing this drug. Can you give some thoughts on that, and perhaps maybe what the ramifications are of overusing these drugs that we really do take for granted that are very easily accessible to us?
Sure. Well, I mean, everything out of the rant of the last few minutes is that I'd actually want to go directly to what Rhonda Patrick has said and look at exactly what she has said and the basis from which she has said it before I can say I don't agree with Rhonda Patrick. But from that statement you have just said, I think you are not going to get addiction from use of a drug acutely for the indication that it is provided. I mean, I'm not a drug and alcohol doctor by any means, but addiction is a chronic relapsing disorder where you have a stage of anticipation, a stage of intoxication, and then a negative phase, and that there is neuroplastic changes that will modulate addiction. So I just want to say that straight up, because that is a very different process.
I probably mixed my words there to be
no, it's fine.
Fair to her, yeah.
But when it comes to dependence, I don't know whether that specifically relates to tolerance, which is an increased amount of drug in order to achieve the same pharmacological effect. So whether she or you are referring to tolerance. But one thing I can say is that, firstly, I guess if you're going to use a simple analgesic like Panadol or Nurofen, I can't comment on whether you would get dependent on it, but simple use. So if your buddy has a big night and takes 2 Nurofen, he's not going to be dependent on that practice. Or I don't believe that with what I know at this point in time. Let's make it as guarded as we can.
It's like doing it daily.
It's like a habit for him, but if he didn't have it, he could just go to work and it probably...
Yeah, he wouldn't shut down.
He wouldn't be like frothing at the mouth for it.
Yeah, I think of older patients who have osteoarthritis who are who are not surgical candidates but want to have symptom control and achieve good quality of life. And if that means that they can take a simple painkiller that is not known to produce any ostensible addictive symptoms, then I don't see any problem with that. But like everything, I think one thing is that if you take a drug, that you need to tell someone about it. You ideally need to have we're lucky enough in Australia, you can have a GP that's involved in your primary care. And before you go off and just take Panadol indefinitely for years, you should tell a medical professional about it so they can work out exactly what's the most appropriate thing. Because if all you've done is just take Panadol for years, there may be better things out there, or there may be ways to get you off the Panadol.
Yes.
So at least involve a primary carer in it, and then you can decide from there. So, yeah, I mean, for period pain, if that's what works, and if simple... I mean, the other thing is that you've got to take it, quote unquote, properly, insofar as if you've got pain, take 2 Panadol at least regularly for a day, rather than let the pain get overwhelmingly awful, and then you take 2 Panadol and you go, oh, the Panadol doesn't work. Probably just haven't given it a fair go.
Yeah, right. So you have to use it properly.
Yeah. And then, it's that old use only as directed. It's like, use it as directed. Follow the instructions.
Yeah.
They're there for a reason. Yeah.
Fair point. Yeah, because I guess what I took from that was that, people are probably, based on that idea, it sounds like we overuse these things a lot.
Do we?
Well, I mean, I feel like we do. I don't really know, right? No one knows what, say, Voltaren does. But, like, oh, you hurt yourself at training. Oh, you can pop a couple of Voltaren and you're going to feel pretty good. And maybe that happens to you once a year. Maybe it happens to you once a month. So then you're using anti-inflammatories every 3.5 weeks. You're doing that for 10 years. I don't know. Is that good?
Well,
I tend to think it's not, because those things are so powerful that there almost has to be a downside.
They're not really that powerful. So as we talked about, with the pain pathway, I said at the periphery there is an amplification as it moves from periphery to the spinal cord. And what ibuprofen or what Voltaren does is it just blocks that amplification from happening. So it stops the pain signal from being amplified as it goes, as the signal is transmitted centrally. So the other way you could argue it is that if you didn't do that, you had just uninhibited pain signals being transmitted, that can lead to a process of wind-up and then can lead to requiring other painkillers down the track. So, maybe an argument is that maybe we're underusing them. Maybe we're just not using enough of them in the right way for the right period of time. If you've got a tension headache, the way they talk about effectiveness of the drug is number needed to treat, so how many people you need to give in order to see an effect. So for a tension headache, if you give paracetamol, number needed to treat is 2. If you combine that with ibuprofen, number needed to treat is 0.5. So does that mean that, really we should be taking 2 ibuprofen with 2 paracetamol tablets? They work in different ways. Perhaps taking the right amount in the right manner, the way it's intended, is actually going to really get on top of the problem, instead of a sort of half-baked way of, I take this every 3 weeks and it kind of doesn't deal with it and now I'm dependent on it. You know what I mean?
I do. Yeah.
Do you take anything when you have a tension headache, as an example? Like, what's your own personal take?
Panadol and Nurofen.
Panadol and Nurofen.
Yeah. On an
Combo.
Yeah.
Glass of whiskey.
My dad always talks about the combo. He loves his painkillers.
Yeah.
He loves talking about that. Yeah, man, it's the combination they say these days, mate.
That is a statement. I mean, I can't fault that, but does that mean, beer and chips? Does that mean, like whiskey and peanuts?
The combo works.
Yeah, there's a lot of combinations that work. But taking the drug in the right way, at the right time, in the right dose, people are like, oh, I take 1 Panadol every 8 hours, every 3 days. You're like, well, that's not doing anything.
It's tough because, like, a lot of people have to, in the modern world, have to keep functioning. So a lot of them assist people carry on the bloody 9 to 5 forever.
Yeah.
Whereas they probably need to take a couple of days off, or they probably need to be sleeping more, or have access to better food and stuff like that. So it does keep people going.
Yeah.
So I guess you have to look at case by case. If you, they help many people.
Yeah, and the beautiful thing about anaesthetics, I mean, for everything that was going to, we just touched on the beginnings of things. It's like anything about physiology is just a rabbit hole. Like when I start to talk about, your painkillers and even nerve blocks, it's a rabbit hole there. The type of ventilation is something else. And when we talk about sleep and nutrition, there are entire podcasts, dedicated to that. But I'm a big fan of, the idea of getting the right amount of sleep. But it sounds so glib when I say that. It's like, really, you're a fan of sleep? But,
dude,
this is
the next frontier.
Yeah. I mean, we were talking about it just the other day, whether that notion is now that you've got wearable technology that can work out how long you sleep, whether eventually you're going to have athletes, now that we're aware of the amount of gains you get from sleeping, whether you're going to mandate amounts of sleep with means of being able to track it. It's a new and scary thing.
Yeah, I actually think it would probably be a good thing in some, much as I don't like the idea of someone monitoring every part of the population, but it's like, the sleep thing. It is an epidemic, right? World Health Organization declared it as such in all Western nations.
Yeah.
So it's like, fuck.
Lack of
sleep.
Too much social media.
Yeah, lighting, all those, all of it. Too much, like long work hours, all that shit. But they can trace a lot of it back to the invention of the light globe.
Yeah.
And as soon as lights became,
productivity.
we just stopped nighttime.
Yeah.
Because the streets became illuminated, so people wanted to be out late, and then our homes became illuminated, so you stay up late. Whereas prior to all of this lighting, you would have just gone to bed.
Just when we talk about
circadian rhythms.
Yeah, but when when you said too much screen time, this is another thing when a statement is put out there. So what do we mean by too much screen time? And this is what I mean.
Social media.
Yeah, but what does that mean? Like, is that you've got to define the problem of what is correct screen time, what is too much screen time? Is it looking at the screen with blue light? Is it looking at the screen without it?
Well, there's lots of little problems inside of that.
Yes.
You want to go into that now? I'll go at you.
Yeah.
It's not just the two. Yeah, I don't.
But that's what I mean. When you want to break down the validity of a statement, it's like what I'd really want to look at is, define it.
Be specific.
Yeah. Be specific about it.
Mate, this is the Jungle Brothers. We make sweeping statements every fucking day.
People make sweeping statements all the time.
Too much social media just before bed when you have to get up really early in the morning and you're reading something that's related to a daytime activity.
Yeah, that's fair.
On Mondays.
On the
after
face of it?
hangover. On Sunday.
What if it helps you hangover? What if it's... Yeah, I'm just stirring really at this stage, but...
Don't. You weren't there when I took the iPad off Wyclef. And he turned into a...
man.
I observed it. I don't need to read studies. No, I actually
that
don't
shit
need
is
to
wild,
read
watching a
studies.
kid have an
I don't
iPad
need to read
taken off
studies
them.
for a lot of things that people want to tell me about parenting.
Yeah.
I can see it, observe it.
It's a beautiful line like that. It's like when you talk about where's the evidence for this guy. Look, it's not anecdotal. I've seen it myself.
Exactly.
Yeah.
We're going to wrap it up there, gents.
Yes.
Unless anyone had a closing thing they wanted to hit the dock with.
I just wanted to let listeners know because they can't see. One, it's Joe's birthday today.
Yeah, happy birthday,
And,
Joe.
and secondly,
thanks, everyone.
He dyed his hair and his eyebrows.
I dyed my hair and my eyebrows.
And
my eyebrows are blacker than my hair.
He looks very odd,
And
almost like a comic, like a
You would
character.
think that it would just make me look kind of like an Italian or
But we're
something.
sitting here looking at this
But it
head while
really fucking doesn't
It's
do
been very
that at all.
distracting the whole time.
I'm going to show you guys a picture of the man that I believe I look like. Now, if any of the listeners out there have ever gotten interested in the theory of the second shooter with JFK's assassination, there was the theory of the second shooter. So there was Lee Harvey Oswald up in the book
got too much
depository,
time, Jay.
and then there was another man because JFK copped shots from two different sides. Just so you guys know, David Ferry. He was I believe he was a covert assassin for the CIA, and he had alopecia. So he was he had like patches of no hair, and he had no eyebrows, and he used to paint his eyebrows on with boot polish.
This is
I
what
believe.
Joe looks
I believe
like.
this is what I look like right
us.
now.
That is what you look like.
Is he not the creepiest looking
He's
fuck
a
you've ever
scary-looking
seen?
guy.
That is really good.
Oh, it's horrible, isn't it?
Oh.
Yeah, so we're looking at this the whole time. It's very distracting.
It says old school mugshots.
And that's
Old school
because
mugshots.
we have our JB Christmas party.
Tomorrow night, the party
night.
of all parties. This is not your average gym Christmas party. This is the JB's fucking Christmas party, and
For this 1 hour, we've spoken about anaesthetics, etc. But every other hour of every day for the last 4 weeks, we've been talking about Christmas party in this gym.
we got costumes. Paul, what are you going as? Oh wait, maybe you don't. Oh no, it doesn't come out till Monday. You say who you going as?
I'm going as Blade.
Nando, who you going as?
TBA.
Wesley Snipes.
TBA, my man. T.
Young people don't know that.
Conan the Barbarian.
Hang on, who's TBA?
Nando.
To be announced.
Oh, duh. Sorry, I ruined your thunder.
Conan the Barbarian.
Sick.
Awesome.
So good. And I'm going as Scarface, Tony Montana.
Heroes and villains.
Heroes and villains
Heroes
is the
and
theme.
Yep.
Mine is very much hero or villain. You can choose. Depends. Usually, if you're a guy, you think he's a bit of a hero. If you're a female, you probably think he's a villain.
It's all vintage, as you said. All of the choices that we've made here.
Yeah.
It is all
Well, that's when the best shit was going around.
It's great.
Wesley,
It's
96.
It's either that or Marvel now, isn't it?
The Daywalker.
Yeah.
That's all he got is Marvel, really.
Yeah.
Yeah.
For
Taking over
superheroes,
the world.
Yeah, it
Yeah,
has.
It's DC as well, but
Yeah, a bit lame.
Yeah,
aren't they?
DC's not quite.
Nando,
got
man,
Batman.
thank you for coming on today.
Yeah, pleasure.
We
Thank
appreciate
you.
you. We appreciate your work. On Wednesday, I'll be appreciating your work, to the fullest degree, while some dude's sticking needles in me.
all the best.
Thank you.
I can happily
I mean-
say you'll be in very good hands.
Yeah, I'm
Especially in
super.
Australia,
I mean,
it's great.
it's funny thinking that people are going to be drilling and doing what, and I'm like, it's fine. Like, because I've had a couple surgeries before, nothing kind of like that, but you just know that it's going to be fine. Which, what a privileged thing to be able to feel that way about going in and getting cut up.
It's a really good thing that you've said that. We should be very lucky that we have this available to us, and you're bang on.
We're wrapping it up there. We will be podcasting next week with the Tim Branston, talking about barefoot footwear and feet in general and foot health. Awesome. He's a legendary podiatrist from down south. Thank you guys for listening. If you enjoyed today's episode, please share it with a friend. Let them have a listen. That's a really great way to support us. We appreciate you guys supporting us, and we'll be training right through the New Year or through Christmas break. We'll have a couple of days off over Christmas and New Year, but we'll be training in between. So do get in touch, junglebrothers.com. Come down and do the thing with us. Thanks, guys.
Thank you.
Thank you.
Bye.